welcome to EuroPCR 2023. My name is Valeria Paradies, interventional cardiologist from the Netherlands, and I have the pleasure to be here with my colleague and friend Shrilla Banerjee from UK. Hello Shrilla, welcome.
Hello.
So I want to discuss with you an important topic. We have been seeing a lot of sessions discussing about the use of mechanical circulatory support devices, in particular in a setting we have to deal with, which can complicate acute myocardial infarction patients, so cardiogenic shock in this setting. I think that's an important topic, and well, we do have a rationale because indeed we want to save these patients, but we also want to save myocardium of these patients. And we know that we do have a system now which actually can help us doing that. On the other hand, sometimes we have to deal with logistics as well. So I want to hear your experience from UK, where you have actually a barrier to usage and widespread adoption of mechanical circulatory support devices in this setting or in all this setting. So how do you deal with these barriers?
Yeah, so thank you. That's a very interesting question. We have a perhaps more evidence-based healthcare policy, and at the moment, because there is limited evidence for mechanical circulatory support benefit, even though there's very anecdotal reports, we only have the Impeller mechanical circulatory support device available in a few surgical and maybe one or two non-surgical centres, and it's on a case-by-case basis and with charitable funding. So it's not centrally funded. So in a non-surgical centre like my own, we only have the intra-aortic balloon pump, and that is a standardised technology that's available to every centre that's doing PCI in the UK. So interesting to see what the difference is between the UK and the Netherlands. Do you have, you obviously have better availability of mechanical circulatory support?
Thank you for this question. Indeed, I mean, we do have access to Impeller, but we also need to deal with, for example, training, so learning curve in getting Impeller in all the centers who are hub center for STEMI. And we also have to deal with cost. And there's something else we have to deal with complication as well. So there's a learning curve in that as well. I think it's important to underline that up to now we don't have a shock network as we have for STEMI. That's probably the direction we are going to. But up to now we have to select patients and we have to anticipate which patients are going to develop cardiogenic shock or are indeed already in an advanced stage of cardiogenic shock and they need Impeller support. And then not all the patients will only benefit from Impeller. Some patients may need advanced upgrade of mechanical circulatory support devices. So do we have in all the centers the access to Impeller, ECMO? This is something we have to take into account when we establish also a shock network. But I think probably standardizing the procedure and really focusing and tackling the learning curve in all the centers, and then how to select patients from upfront, from the ambulance, which patient need to go to a hub center where the patient can get the best of in this term of support. So I think that's the direction we are going to. What do you think?
Yeah, I think that's right. So when we use the Sky Shock classification, which is a very elegant way of defining the different stages of cardiogenic shock, we know that probably in level A, there's probably no need for any mechanical circulatory support, and level E, which has the worst mortality of about 80%, it's probably too futile. But in groups B to D, there probably is a role for mechanical circulatory support, and this has been hypothesized. And I think hopefully the data will show us within the next couple of years that this is the target population we should be looking at. There are other markers of risk like lactate as well, and other risk scores as well, which have been very useful in defining which patients should be watched more carefully for signs of cardiogenic shock, and then perhaps transferred out from a centre like mine to a shock centre. It's disappointing that shock centres only have a level 2B evidence. It's actually to transfer up to shock centres. So hopefully we can refine the processes in the future and make this make an impact on the mortality really of this very catastrophic presentation.
Well, I think probably the evidence coming from latest trials, so randomized data showing that indeed we can really impact on infarct size, so we will save myocardium, and then consequently the risk of developing heart failure in this patient probably will demand some a better organization of the network. So I think while we wait for this randomized data, we have to deal with local logistics, but we have to think ahead, and to think that a better collaboration with spoke and hub centers is indeed the direction we are going to, and train the physicians how to use these devices, because this is indeed what you're going to deal with in the future.
Yeah, I mean, we've done it for heart attack, so I don't know why we can't do it for cardiogenic shock, really.
Indeed.
There is something to be said also that we have other means to manage cardiogenic shock. It's not all mechanical circulatory support. We have the evidence base is showing that there is clear benefit in inotropic support of any particular brand or kind, and there's obviously benefit in ventilatory support as well for reducing hypoxemia and correcting acidosis and providing some airways protection for patients who are perhaps peri-arrest. And most importantly, it's to open the culprit vessel as soon as possible in a timely fashion, because as you said, you save myocardium.
Indeed. So I think, we have elements, and well, we do know that indeed prompt revascularization is the target, but also indeed support the myocardium. That should be our target. Well, I thank you so much, because that was an interesting topic, and also to see your perspective from UK, where indeed there are logistic buyers. Probably in the future, with more evidence supporting the use of these devices, we'll probably kind of broaden our, open up our possibility to use these devices more. And well, thank you for your time, and I thank you all the audience, and enjoy the rest of the conference.
Thank you.